Good evening, everyone. My name is Erica Marsh, and I am the Faculty Director of Community Engagement for the Michigan Institute of Clinical and Health Research. And I am so excited to welcome you to our town hall meeting on COVID, and specifically on communities conquering COVID. Thank you so much for joining us. If you would prefer to listen to this presentation in Spanish, please choose the option Spanish that will show up on your screen close to your navigation bar.
Muy buenas tardes.
And I will take a few seconds to allow everyone who wishes to listen to this in Spanish translation to do that now.
Muy buenas tardes. Si prefiriera escuchar esta presentación en español, favor de escoger la opción Spanish que aparecerá en su pantalla cerca de la barra de opciones.
To have you join us. We know how busy and long days are, but we wanted to start a monthly opportunity for people across the state to get their questions answered regarding COVID, the vaccine, testing, and any other questions that you may have, to make sure that we're all moving toward a healthy, whole community. We are so honored today to have two special guests that I will introduce shortly, but I want to start with a couple of questions that everyone can complete via the poll. The first question, which should appear on your screen if you're on a computer or a phone or an iPad or tablet, is: have you received the COVID-19 vaccine? Yes or no? Again, number one is: have you received the COVID vaccine? Yes or no? Please answer that question. The second question is: if you have not received the vaccine, how likely are you to get the vaccine if it were available to you? And we know that's a big if, and there's some questions that we're going to answer about that tonight. But if you haven't received the vaccine and it were available to you, how likely are you to get the vaccine? Please answer. All right. Thanks, everyone, for completing the poll. We're going to move on with the program. Next, I have the honor of introducing our two special guests tonight, both experts in their respective spaces. I'm going to start with the introduction of Yvonne Lewis, who I've known since shortly after moving to Michigan here 4 years ago. Ms. Lewis is the founding director of the National Center for African American Health and Consciousness, and she has led several community-based efforts at the state and national levels that have had significant impact for community engagement. These include the Michigan Multicultural Network and Improving Cancer Outcomes for African Americans in Michigan. She has served as the initial chair and led the process to organize the National Community Committee for the Centers for Disease Control and Prevention. She's also a founding member and past chair of the American Public Health Association Caucus for Public Health and the Faith Community. At the local level, which for her is Flint and Genesee County, she helped organize the Faith-Based Health Team Network. She was an organizer and past chair of the community-based organization partners known as CBOP, and she was the first community chair for the Michigan Prevention Research Center. She is currently community principal investigator for the Flint Center for Health Equity Solutions, funded by the National Institute of Minority Health and Health Disparities. And she's co-director of the Healthy Flint Research Coordinating Center Community Core. She recently joined the Rogel Cancer Center Community Outreach Community Advisory Board. I'm very proud to welcome one of our special guests for this evening, Miss Yvonne Lewis, to bring her expertise on research in the community, her research on the community overall. We're so grateful for your presence. We're also very fortunate to have Dr. Sandra Cinti as one of our special guests. Dr. Cinti is a professor of infectious disease in the Department of Internal Medicine at the University of Michigan and the Ann Arbor VA Medical Center. Dr. Cinti is an expert in biodisasters and bioterrorism and has been part of the biopreparedness efforts at the local, state, and national level. He currently sits on multiple committees at the University of Michigan Hospital, including the Disaster Committee, the Pandemic Influenza Committee, and he co-chairs the Scarce Resource Allocation Committee. I think most relevant for us is that Dr. Cinti chairs the Washtenaw County Society Pandemic Influenza and COVID-19 group, and he has been an advisor to local and state public health departments on the issues of COVID-19, influenza, bioterrorism, and biopreparedness. He is currently co-chairing the Michigan Medicine COVID Vaccine and Therapeutics Task Force, and we are also very honored to have him join us tonight to answer your questions. We're gonna, without further ado, I'm gonna hand the floor over to Ms. Lewis and have her speak for a few minutes on the community's perspective and experience with COVID-19. Then we'll hand it over to Dr. Cinti for his perspectives from a medical perspective on COVID-19. And then we're gonna spend the vast majority of our time tonight answering your questions. Thank you for all the questions that you sent. We're excited to get as many of them answered as possible. And if we don't know the answer, we will not make anything up. We will do our homework, get the answer to you, and follow up with you. So thank you for this opportunity. And Ms. Lewis, I will hand it over to you.
Thank you, Dr. March. You always tell me just call you Erica.
Yes, please do.
So thank you for that introduction and the opportunity to be a part of this session tonight. As you know, most of you know, you mentioned the coronavirus. This has been a real concern for us in the community from the beginning. And it's wonderful that we have community and academic partnerships that can help us bring some credible information along with a number of partners. One of the things that we're excited about through the Healthy Flint Research Coordinating Center, which is a community academic partnership, is that for this week now, 46 weeks, we've been talking about this issue of the coronavirus. What does it mean to our community? Because as all of us heard in January, early February, this pandemic was coming across the nation and the world. Our issue was, what do we do about it at a local level while we understand what's happening at a national level? In March, and we never shall forget that day, March 16th, we were planning for a symposium where we were going to really look at the research that had been taking place in Flint, particularly Genesee County, and share that. But what we found is we couldn't do that because our state was shut down as a result of the virus. So what do we do? So we work together as a partnership, and we're appreciative of all the over 45 community partners across Genesee County who've helped us get information to our community members. Number of questions. Where do we go to get food since the schools are closed? How do we get around using local transportation? How do we understand, what do we do? Go to the hospitals when you're being told, don't go to the hospital because they're overrun. So there were a number of questions. I personally want to take this opportunity along with all of our partners and say thank you to the communities members who helped us gather questions that could be answered. So tonight, as a part of that, I see this as an extension of all that work that's done, that we can get more in depth on answering the questions. These are questions that came from you. All of us have many, many more questions, and we'll just begin tonight to answer those questions. So there's more to come. Dr. Cinti.
Oh, thank you. This is great to be here, and I agree with Yvonne that this is just a great opportunity to talk about the facts and answer the questions that you have. And I don't want to spend too much time talking except to answer your questions. We have it's been really rough at the hospital level. where we've had patients and constant influx of patients with COVID. Many of you know that. Many of you have had family members with COVID, and the outcomes aren't always good. The vaccines here, we're excited about that. There have been problems getting the vaccine out because the supply isn't what we would expect right now, but it's coming, and the vaccine is safe, and it is a positive thing. There's light at the end of the tunnel here, and I want to reinforce that tonight. So I will stop here, and also let's get to the questions, and hopefully we can answer some.
There are a lot of questions, so we had to kind of categorize them,
Okay,
Doctor, that we make sure we get to them all. And I know we'll be talking about this virus now for over a year, actually.
That's right.
And we still have the basic question that I'd like us to start off with. Just tell us, what is this virus? And, help us to understand, is it a one-time thing? Is it just coronavirus 19 and that's it? Or how do we understand just the virus itself?
It's a great question. This virus, SARS coronavirus 2, part of it is that part of the reason that these things happen is because there was probably some exposure to some animal, a bat, in some part of the world. We think it was China, where this first occurred. And the virus changed enough that it was able to infect humans and cause the level of disease that we're seeing. There are other coronaviruses out there. Many of you have had them. They're the common cold. This one has been much more serious, as we know. It's changed too a little bit as we have a lot of people that get infected. We have a new strain of this virus. It's not worse, but it's spreading a little more quickly among people. It's a variant strain. And so it's not resistant to the vaccine though. So this virus is transmitted among people through the air, through contact, with coughing, with close contact, and that's why we have to maintain our distance and wear masks. And it acts very differently in different people. Young people do pretty well with this. Older folks have a lot more trouble with it. Some do fine, some people do worse. We'll talk about what those risk factors are. We'll get through this. And eventually the viruses change, and populations, like the human population went through pandemic flu, and we eventually got used to the virus, and it ended up being a less problematic virus. But that would take a long time if we didn't have vaccine and didn't try to get through this with vaccine. So I think we'll have some questions about that too.
Right. So you did mention that there's a shift in the virus. So you say it changes, it mutates.
Yes.
It doesn't say the same. And
yes.
that can you just tell us a little bit about what causes that change?
Yeah. So you guys, everybody out there gets a flu shot every year. Not everybody, but you're supposed to, and we have to in the healthcare setting. That's because the virus, the flu virus, can change a little bit every year. 1 year to the next, it might be the same vaccine, but every year you have to get another vaccine. We may be at that level with coronavirus because it mutates. The viruses are smart; they can change, and when they get pressure, and when they change naturally, just from one day to the next, from going from one person to the next. Now, the good news is the coronavirus changes a little bit less quickly than the flu virus. But the problem is when we have huge numbers of infections all over the world, that a little bit of change turns into something that's pretty significant. And so we have to be aware of that. I think the good news about Michigan is we have a governor that's really worked hard to bring the virus down. And whenever she's been able to run the show, we've had decreases in cases. And so I'm very encouraged that she continues to be able to do that. And the lower the number of cases, the less that pressure is for the virus to change.
Yeah. So Doctor, one of the things that we say in community is we really need some transparency and some real clear answers. So some of these questions are to get at the clear answers, the questions that people have. And so we're going to just pause for a moment and ask you, if you weren't able to get your questions in before, you still have an opportunity to put your questions in the Q&As, and they will make sure, if we can, get to those questions tonight. So talking about vaccines, you said there's hope. This is a good thing, so we're told. But how many months, the question, how many months were the Pfizer and Moderna vaccines studied in phase 3? And so we may need a little understanding of what we mean by phase 3 as well. But how do you know?
Yeah, so the whenever any kind of drug, any kind of vaccine has to go through these stages through our FDA. Phase 1, dosing a little bit more.
I'm sorry, Doctor, we've lost your audio.
Can you hear me now? Is that
Yes,
any better?
Perfectly.
That's much better.
Sorry. English didn't work for me. When I put it in English mode.
You're talking about the phases, Dr.
Yeah, the
Cinti.
phases. So phase one is we test to see if something is safe, and then as the phases go along, you want to get to phase 3. Phase 3 is where you test it in a whole bunch of people. You look at safety, you look at efficacy, you look at your doses too. By the time you get to phase 3, most of the time they know the dose that we want to use. So this vaccine was done in phase 3 trials in 30 to 40,000 people. So the Pfizer and the Moderna were both done in that many people. And they have 2 months so they gave one vaccine, and then for Pfizer, 21 days later, another vaccine to each person. And in Moderna, they did one vaccine, then 28 days later, another vaccine shot. And it's a shot in the arm. And then they followed them for 2 months to see if there were any problems. And in vaccine treatments, it's not always that way with other medications, but with vaccines, typically the worst problems are going to occur within that first 2 month period. So once that first 2 months passed and they had all the data, they could say, this is a pretty safe vaccine for both Moderna and Pfizer. And we all looked at that. Our FDA have panels that look at that. Our CDC have special advisory panels that look at that. And they said, good. And it was good. And to give you one example of how stringent our FDA is, there was another vaccine strain out there, AstraZeneca. And AstraZeneca did their studies, but they weren't fully done enough to be good enough for our FDA. So even though, but England said, we'll take it, and they started using it. Our FDA said, not ready yet. We need more data. And so it shows you how the safety is important at our FDA. And I want to continue to stress that. And we would not be putting it into any arm if we didn't think it was safe.
Well, we appreciate that, because we don't hear a lot of clear information about how the trials were run. And then, when you hear warp speed, is something being left out of the process? Yeah,
and I can tell you a little bit. So the way they did the trials, it's called a placebo control trial. So you take one person, each person gets a shot, and one person will get the actual vaccine, and the other person will get what's called a placebo, a shot of normal saline in the arm. And then what they do is those people agree to do that. It wasn't done. They said, yes, I agree. I agree that I might not get the vaccine shot. And then they follow those people. And what they would say is, if you get sick, you got to come in. And when those people got sick, they tested them for COVID. And what they found is that the people that got the vaccine for both Moderna and Pfizer, the people who got actual vaccine, 95% less of a risk of getting COVID. Not 100%, but 95% is better than you'll see for almost any vaccine that we have. It's really remarkable.
So if I could just say it in simple terms, 95 people out of 100.
Right, 90, are protected, completely protected. Okay. Yeah, with the ones that got vaccine.
Right. So you spoke about the Moderna and the Pfizer vaccine. A question, do we have a choice at which one we get?
You don't right now. There is no choice. There isn't choice. They're both equal, though, in terms of side effects and in terms of how effective they are. There may be a point at which people have a choice, but I have to tell you, if I was given a choice between these two, I would say, which one can I get first? Is the answer to that. So it may be a little bit different with the new vaccines coming up, AstraZeneca and Janssen, but we still have to see.
I know this is a little bit later on, but I think right here is since we don't have a choice, when you go to get a vaccine, how is that decision made?
So it depends. So what was happening is the nursing homes, for instance, they got all Moderna vaccine.
Okay.
And so anybody who was in a nursing home in Michigan was getting Moderna vaccine. Most of the hospitals, because we had these cold freezers that could hold the vaccine, and they got the Pfizer vaccine. And so we got only Pfizer vaccine for the last 35 days. We finally got a few doses of Moderna, so we will start giving Moderna also. So it depends. And still, even if you come to our place, you can't say, oh, I want to go in the Moderna line or I want to go in the Pfizer line. You go, it's wherever it's what's being given at that place at that time.
So it is based upon the facility that you go to get the vaccine. All right.
And you have to get the same one twice, right? So you can't get Moderna one time and Pfizer the next. You have to get them. You have to get Pfizer, then Pfizer, Moderna, then Moderna. Right now, the way it is.
Great. Okay. Dr. Marsh, I see.
Ms. Lewis, can I ask a quick question of Dr. Cinti? Dr. Cinti, you mentioned the need for cold or super cool freezers for the Pfizer vaccine. Why is that important? How does that impact the distribution of the vaccine? Can you talk to us a little more about that, please?
I absolutely can. Would it be useful if I said how the vaccine worked, actually, how it goes in and works? That might be. So what it does, the vaccine is a little piece, it's called mRNA, that it is given in the arm, and then it goes into the cells, and it gives a message to the cell to start producing the what's called the spike protein. It starts producing a portion of the virus, not the virus. So you're not given the virus. It just is a little portion, enough so that your body can say, I recognize, let's attack that. And then it recognizes that portion. The image I use is, if anybody's seen Mission Impossible. So everybody know Mission Impossible. There's the main character. I think his name is Tom Cruise, and he'll get a message, and the message will tell him what he has to do in order to save the world. The message then disintegrates, and that's what happens with this vaccine. It goes into your arm, it gives the message to protect you, and then it goes away. And the reason we have to give the freezing temperature is because it's a very delicate, that little piece of mRNA is very delicate, and you have to wrap it in what's called a nanoparticle. And that's a little bit of fat. And that nanoparticle has to be in cold temperatures. And so that's the only way that they can get it safely and effectively to your arm and into the cells. So that's the long story of why COVID has to be cold.
That's helpful. Thank you. Yeah. And it's not the vaccine. We're not being given the virus, right? We're not being given COVID-19. Okay.
No. The message,
So now you use some terms, doctor, that I'm gonna have to help you got to help me out with, right? So
Absolutely.
You said mRNA, and that M is a little m that stands for
messenger. Messenger.
And the RNA is?
It's a piece, DNA and RNA, they're pieces of, their DNA is and RNA are, what carries the code of messages for life.
Right.
It's like it's a blueprint.
Yeah. So some of us remember when we talked about the code, that the human genome, and we can get to some of that. It's like the little parts that make us all up, the little genes that make us all up.
Yes.
And so just kind of put some context so we can understand, because these are some technical terms.
It is very, it's hard enough. It took a long time for us to understand it within the medical field, but these are beautifully done studies too.
Yeah. So a question, if a person now gets this vaccine, does that mean they won't get sick? I think you mentioned a little something about it before, but.
That's a great question. So the reason to get vaccine, there are many reasons to get vaccine. The first reason is to prevent you from getting disease at all. It prevents you from getting sick 95% of the time. So 95% of people are protected from symptomatic disease. So that means the COVID disease that makes you appear sick. You get fevers, you get chills, you feel bad. It might not protect you from asymptomatic disease, though. We don't know that. We don't know that. You might still be able to get it and then pass it to somebody else, but you're going to be fine. And furthermore, it may protect people even who get sick from getting, so say you're one of the 5% that gets sick, but that will still protect you from getting so sick that you end up in the hospital. So it's a game changer in terms of how it looks. If enough people get the vaccine, and we say about 70% of the people in this country, that will make this virus go away, basically. But we have to get that many people vaccinated.
Yeah. So here's another question. We've had this coronavirus now for all these months. Many people have already been sick. So now, if they have been sick, can they still take the vaccine? And is there a wait period after they say we've recovered before they can get the vaccine?
Absolutely. Yeah. So there is. So you have to be through the illness phase of the vaccine. What they say is 2 weeks after you've been sick, you can then get the vaccine. You're protected now. If you or I or anybody here gets coronavirus, we will mount a response and we will be protected. And what the CDC says is you're protected for at least 3 months. Now, that doesn't mean you shouldn't get the vaccine. And we're still telling people that if you had the disease, you should still get the vaccine because you'll get, we think, extra protection. But if you're in line in front of somebody who hasn't had the disease, some people are deferring because they want to allow other people to go ahead of them because they know I'm safe for 3 months. Even more probably 3 to 6 months, 8 months, people are safe after getting that, but they can get it. And if you have a chance to get it, I say get it. Yes.
Okay. But you are saying there should be a little bit of a wait period once they've gone through the recovery process.
Yeah, at least, so 2 weeks from the time you first get symptoms, that's what the CDC says. You don't want to get it when you're sick because what it could do is make an immune response worse. But once you're better, it's fine.
Okay. So that leads to the next set of questions, Doctor. When you've already got this, then there's what will happen if I get it? Is there side effects? If I get
yes, I don't want to minimize this. The side effects are not terrible, but if anybody's had the shingles vaccine, the Shingrix, it can cause quite a bit of arm pain. Some people, it's really worse with the second dose. I got my second dose on Thursday this past week. And on Friday, I had muscle aches and I had to take a couple ibuprofen. I still went to work. I still did everything I wanted to do, but my arm hurt and I had some muscle aches. And most people get those kind of side effects. Otherwise, a few people get fevers. Maybe 10% can even get a fever, maybe 10 to 15%. But other things, there's a very few, very, very low rate of some people getting what's called an anaphylactic reaction, where people have had an allergic reaction, basically it's called, where some people have had hives, where you get itching and red welts, or some people have had feeling like they're short of breath. Nobody's died, but we've had to treat some people, maybe 1 or 2 out of 35,000 now, who needed to get a treatment, maybe Benadryl to tamp down the system. But that's the worst of it right now. And most people, and actually this is much safer, it turns out, in older folks as opposed to young folks. So older folks have less of all those side effects I've talked about.
So at 65 or 66, I ought to be okay, right?
Yes.
Okay, so thank you for answering that, because that was a question. So, tell us what happens after that second dose, because many people are concerned because they've heard a little bit about it being more of a challenge after that second dose. But here's another really interesting question about the doses. You said to wait a little bit. So there is a wait time after you get the vaccine, and that's to ensure that there's no reaction.
Oh yeah, you mean wait at the place where you get the vaccine?
Yeah, so people should expect to have to wait a little bit. Yeah,
15 minutes. Now, what they say is if you've had one of these anaphylactic, so people who carry an EpiPen or have had an anaphylactic or a very bad allergic reaction to, say, bees or penicillin, they'll make you wait 30 minutes. It doesn't say you shouldn't you should still get the shot, but they just have you wait a little bit longer. So 15 to 30 minutes is what we say.
Okay. So one of the reasons we have these conversations, and Dr. Erica, I've talked about this, is because we want people to be able to make an informed decision.
Yes.
So to plan ahead, if you have the opportunity to get the vaccine, plan ahead so you have the time to do the things necessary to be as safe as possible.
Yeah, absolutely. Agreed.
So when we talk about safety and being informed, there are people who have underlying health issues.
Yes.
And so what are your recommendations for those, and what kind of research has been done on people who have things like heart conditions or diabetes?
You want to get vaccinated, and actually the vaccine is safe though. So of those risk factors, most of them were represented in all those studies. So one of the problems, so let's take pregnancy, for instance. Pregnancy, there weren't any pregnant women in these studies, but we're still saying it's important enough because pregnant women are at risk that they should get the vaccine. So the OB societies, are saying it, and so our OB doctors are saying, please get the vaccine. Lactating women who are breastfeeding should also get the vaccine. There haven't been studies done, but there's every reason to believe it's going to be safe. And in those other populations, so somebody with heart disease, somebody with diabetes, somebody with sickle cell, all those are high risk conditions. And actually they're going to be ahead of the line in the next phase, 1C, in order to get this vaccine.
Well, you just stepped right into another question, Doctor. Talk about that next phase.
I didn't know what you were going to say when you said I just stepped in it.
Next phase 1C, because this priority is going on here. So we're encouraging people to talk to their doctors, but what about this 1C? What does that mean?
Okay, so right now we're in 1B, and many people know that, they've seen it. And 1B is really to protect our people 65 and over, and it's people who are called frontline essential workers. These are people who can't help but be in close contact. So it's our police and fire, who, a fireman has to go in and fight a fire and save people. And he might have to save somebody who has COVID. So he's not going to stay 6 feet away from somebody like that. Teachers are in that 1B risk, because you can't expect a teacher in a classroom not to be close to the kids and stay 6 feet away all the time. Faculty at colleges, they can stay distant. And so they're not in 1B. 1C then says other essential workers. So it would be other people within the transportation fields, people who have been staying far apart but can now get vaccinated. So those will be, and frankly, Yvonne, I have to say 1C may change, because the CDC is going to go back and say, okay, how much vaccine do we have? And they're going to change those. So if anything I tell you here is very likely going to change. So, but it will be folks who are considered one of these essential worker roles. And we're going to probably we won't finish 1B and then we'll start 1C. Once we get enough people in 1B, just like it happened with 1A. 1A was healthcare workers and people in nursing facilities. And as soon as we got most of those people vaccinated, the state said, let's start 1B. And I think they did the right thing doing that. So
Doctor, I think a couple of our listeners are going to be very happy that you said there might be some changes, because we have a question here about someone who had medical history.
Yeah.
And they feel that puts them at higher risk. So they should be moved up into that 1C category. Or
they will be.
Okay. Yeah. So, and if a person's physician, for instance, in this case, a neurologist, says they should be moved up, their question is, what do they have to do to prove it to someone else that they need to be administered this vaccine?
Well, it's hard to even get a physician's note. I've had my own colleague call me and say, how can I get this patient or my mother who's 85 up on the list? And we can't do it right now. And so you won't be able to get your physician to do it unless we suddenly get so much vaccine that we can give this to clinics, but we can't. Every vaccine, people think about vaccines, I go to my doctor's office and I get a shot. That's not the way this vaccine is given. This vaccine has to be given in a mass vaccination in a big place where you have to make an appointment. You can't just show up. So it makes it very, very difficult. And what I would say to people is most of the time you're going to be able to call in. Some of the time you're going to be called, and you can't. At University of Michigan, even as a 65 and over, you have to wait for the call in order to get to schedule. It's as well as we can do. It's as efficient as we can do it. It's as fair as we can do it right now. People would argue that, but we're trying to be as fair as we can. And that will continue to be the case.
Yeah, and we appreciate you hearing that. And yet there are some instances where people hear differently. You know, they hear that somebody in a less risky position had an opportunity to get a vaccine. Even they specifically stated at the university. So how do we respond to people who say, but that doesn't sound quite right because my experience has been a little bit different. I know somebody who kind of got ahead of the line. Yeah,
and Yvonne, I like to believe in the better nature of people most of the time. So I don't think most people are trying to jump the queue. And as a matter of fact, my experience has been that my colleagues have come to me many times and said, why am I part of this group when I'm not seeing patients right now, but I've got an invitation. I think I shouldn't do it. And they complain in that way. There are people who can get into the system. There are problems sometimes where people can show up and they'll be able to get a vaccine. That shouldn't happen, but it does happen. You'll see a young person getting vaccinated. And what I would say is don't assume that young person jumped the line. That young person may be a student, a nursing student who sees patients. It may be a pharmacy student who is rounding on the wards in the hospital. It may be a public health student who's out there. And so that person would appear young and healthy, but they're on the front line. And at the university, we would have considered those people actually 1A, the top tier. And we're still vaccinating those people. So yes, it does. I can understand that people who are 65, 75, and they see a young person getting vaccinated, it makes them mad. It makes them scared. It makes them, I'm not going to get up there. I'm not going to get my turn. And it took me a while to understand this. I thought when we got this vaccine, I said, everybody just wait, you'll get it. It'll be fine. But when it's there and you've been working so hard to keep your family protected, to keep yourself protected, and then it's within reach and you can't quite get it. It's like a bad dream. And so I understand the concerns that people have, but we're trying to do this as fairly as possible.
Doctor, I think this is another reason why these conversations are so critically important.
Yeah.
Because it gives a different perspective. No one would think that maybe there was some other issue behind the circumstance that made it important for that to happen, especially when if going to the series of questions about vaccine availability and distribution, I got my hand raised. We're people now in community who have their hand raised. We talked a lot about vaccine hesitancy. Oh, I don't want to get the vaccine, but they're raising their hands. And
that's great. That's great. And I'm appreciative of that. Yeah.
But the vaccines aren't available. So what's that next step? Are the health systems and the health departments working together to distribute the vaccines in a way that everybody can get a vaccine if they want it?
Yes. It doesn't always seem as efficient, and it's a lot of times it isn't as efficient as we'd like it to be. We're trying to develop. So in Washtenaw County, we're trying to develop some communications where we communicate together with the public health and with the other hospitals. It's very difficult. We are working together. I meet with my cohort meets with Dr. Juan Marquez, who's the Washtenaw County Medical Director, and his group once a week. We're meeting. Dr. Marsh brought up Dr. Erica. I'm sorry, brought up the Washtenaw County Medical Society. We meet, and when Dr. Marquez is on that group, we have people from St. Joe's on that group. So we're keeping in touch, and we know what we're doing. It doesn't always seem organized, or it is organized, but it doesn't always seem coordinated. But each of us, so at University of Michigan, we're focusing very much on our patients who are now 65 and over, because we have 150 to 200,000 of those people. It was a stunning number to me, but we have to focus on those people. We're also, we've been tasked with focusing on the front line, those people on our campus who are frontline people, transportation people, the environmental services people on our campus, those people who can't help but have close contact, childcare workers. We are focusing on those. And public health, on the other hand, is Dr. Marquez and his group is focusing on teachers, and they're looking at, because they don't have enough vaccine, teachers over 50. People who are working grocers, they're going to be in the line pretty soon. St. Joe's is taking care of their patients. IHA is taking care of their patients. So we're trying, but there are people who cross over, right? Mm-hmm. And so the confusion comes when somebody says, "Yes, I work as a teacher, but I'm also a member of the University of Michigan patient crew." But we're doing our patients over 75, not our essential workers. So then they have to go to the public health and they get really upset. Why? But there are reasons. And the reason is moving people through and getting vaccine out.
Yeah, and one thing we've learned in our experience is that there are various sites, and each community is working to do the best that they can, getting information from the state as when vaccines will be available, and then the distribution. So there are different distribution sites across our communities.
Yes, absolutely, there are. And what I would say is, when somebody sees somebody they think oughtn't get vaccinated, and maybe that person shouldn't get vaccinated, but for that person, there are 10 or 15 or 20 people who should get vaccinated and are getting vaccinated. So I think take a step back and say, yes, you're not getting your invitation yet, but you will. And that one person is probably a minority group that's getting, and most of the people are getting the vaccinations who need to get those vaccinations.
Yeah. Now you talked about 1A, 1B, seniors and first line workers. So the question is, do you have any idea when the 1C just might be able to start squeezing in?
Good question. And the answer is, it all depends on vaccine availability, right? If the vaccine, if I knew that I could have we could have as much vaccine as we wanted and as much vaccine as we could put through, we could tell you that number almost to a day. But we can't, because I don't know from 1 week to the next how much vaccine Michigan's getting. And I don't blame the state, because they are having the same problem when they're asking for it from the national government. And I don't blame the national government, because it wasn't, they got a vaccine supply that I think they were told that there was more there than there actually is. So they're producing it as we're going.
Yeah. So you mentioned all three layers of concern. You mentioned our federal government. So we know President Biden, he's made this declarative statement of what we're going to do in the first 100 days. And then we know the states are depending upon the federal government, and our local communities, our counties are depending upon our county health departments. And our local communities are depending upon the health departments and the federally qualified health centers. So it really is incumbent or necessary for all of us to try to, it's hard, but take a deep breath and try to figure this out. But we really need good information coming from credible voices such as yours to help us work through this. Yeah.
No, I'm happy to do this, actually. I mean, I think it's very important. And there are people, even within our own hospital, imagine this with it, there are people who, for certain reasons, don't get the emails that we send out through our Blue Queue, which is the way we were sending invitations. And it took a while for us to realize that we were missing a whole bunch of people, and so we're making an effort to go to these huddles to see where the people have to go right before they go to work, to say, hey, listen, we got vaccine for you if you need it, because you're still in 1A. These people are still in the high category. So we still have to do a lot of education within our own walls, and outside. So I'm happy to do that.
So one of the things often that I'm concerned about as a community advocate, I like to call myself, is how we communicate these messages and the words that we use. So one phrase that's been used is we're going to distribute the vaccines in a randomized fashion. And so we really need a little bit of help to understand. Somebody said, is it like the lottery, just throw your hat in or pull out a number? And so it feels like then we start to fight against each other. That's not what we want to see happen in our communities.
You're right, Yvonne. That is a great way to think about it, that you don't want to fight against each other. See, when we make these decisions about prioritization, and really we have to follow what our state says. So to a certain extent, we can do what we want, but really, when the state says 60, we thought it was going to be 75 and over because the CDC said 75 and over. So we were getting ready for 75 and overs in 1B. But then the state said, we're including 65 and over. And so there's a problem there, right? Because 65-year-old and an 85-year-old don't have exactly the same risk. But what we're balancing here is the need to be able to get as much vaccine to arms as possible to get people through, and the need to be able to do it in a fair fashion. So we have a scarce resource allocation committee. We have our ethicists. Ethicists are people that many of you have talked to these people. They're the people who think about what's ethical, what is the right way to do something. And randomization, actually, where you do a kind of a lottery, is actually a fair way. It's putting everybody in the pool and saying your likelihood is as good as anybody's, and that's fair. And so we're going by that right now, unless we're told by the state that we need to sub-prioritize, meaning that you need to do 75-year-olds first, or 85-year-olds, then 75-year-olds, then 65. But I don't think they will, because that will slow things down completely. As you can imagine, when you really start to slice the pie, you could have a number from 1 to 300 million for vaccination, in that could be the list. But to be able to do that would take too long. So we have to be careful that we don't sub-prioritize too much. And I think that's what the state's doing. They're thinking about those issues. So I don't want to sound like I'm hedging, but really randomization is a fair way to do things.
Yeah, because the question becomes, who's deciding? When we look overall at our community and we see the disparities, we see the confusion, we see the frustration, and then you see the list start to dwindle down and you don't know how that list is being generated.
You're right.
It's a question about who's deciding and how.
Right. And how do you get people? So who's deciding and how do you get people on those lists? So, what will be great is to have everybody on the list and then randomize it. But there are people who are outside because we're not able to get in touch with them. And that's part of this effort to say, talk to your health department, talk to your hospital. Everybody's got ways. It may take a while. It's not quite like trying to figure out Social Security, but it's pretty it might be difficult to figure out where you get the vaccine. And what we're telling people is, put your name in wherever you can. It's not going to hurt the whole process, but put your name in there. And there are places that can tell you where you ought to be putting your name into. At the University of Michigan, you can't put your name in anywhere, but at the health department, you can put your name in if you're 65 or over. And so it's not perfect, and it's going to continue to be an issue, I think, Yvonne. We don't have a great way of getting everybody into that randomized pool. Right. But I think what I want to say is, if we could, everybody would agree that the best way to do things would be to say, it's called the big blender, and then you pull out a ball and say, you're next. Yeah. And as long as what you're saying, Yvonne, is we don't have all the people we should have in that mix.
Yeah, because one of the questions that came forward was, what about incarcerated citizens? Are they included in the closed housing bracket? How are they fitting in? Because, they're in confined quarters. So there are a number of population groups that we don't have good answers for how they're going to get connected to, but it's helpful to understand that there is some conversation about it.
Yes, and then the prisoner population, I don't know where they fit. I think they're going to be in category 2, but the risk, people who are at risk within the prison system. So somebody who's 75 and is in prison will get vaccinated. They should be getting vaccinated. And we're not doing that's not part of what I'm doing, but I think public health should be monitoring that and doing that. And we should ask them, how is that being done? How are we identifying those people? I think we probably are, but we should make sure.
Well, there are a number of questions in the queue, and I'm not sure we're going to get to them all tonight. I'm sure Dr. Erica and her team is going to make sure they categorize these numbers, these questions, so we can get back to you. But I hope this information has been helpful to you. It's not an easy discussion. We don't have answers. I use the weatherman analogy often. They say partly sunny, partly cloudy. Get your umbrella out, because we know that these things are changing on a regular basis. But what I'm excited about is our opportunities for community members to get their questions answered. They may not all be the answers that we want, but it helps us to keep pushing to get the answers. That's why our community-based participatory research efforts are so incredibly important, so we can hear those voices. Doctor, I'm going to have to turn this back over to Dr. Erica, but Dr. Sandro, if you've got some closing remarks or comments and something that you really want our listeners to know tonight that we can walk away from here with, please share with us.
I want to say these are safe and very effective vaccines, and you'll all get vaccinated. Anybody who wants to get vaccinated will get vaccinated. And just to say, this is all a good thing. We've never, ever been in a place where we've been able to get a vaccine to arm in less than a year, which is what happened here. In 10 months, we went from researching to getting a safe and effective vaccine to people's arm. Remarkable. And it will be life-changing, and it's saving lives right now. And we all need to know that. I know that people wanted to save theirs and their families. It will, but I can say be patient. I've gotten my vaccine, but I don't want to, I think being patient is going to work out for everybody here in the near future. Thank you.
Thank you. Dr. Erica? We've used up all of our time, but the list is about this long. We got some other tough questions people want answers to.
Absolutely. And we knew we had the right two people to kick off this series. I cannot thank you enough. I call you sis, but formally Miss Yvonne Lewis, thank you for bringing your wisdom and expertise to bear. You always bring it correct. And we knew you were the right person to moderate this session. Sandra, Dr. Cinti, you always bring it correct. Thank you. You were the right person to bring the medical expertise piece of this to bear. And to both of you, your extraordinary expertise in your respective spaces, your extraordinary expertise and your lived experiences. Thank you so much to both of you for bringing that to bear and for helping create healthier families, healthier communities, a healthier state, which is what we want. I want to just take a few minutes to thank the behind the scenes team as well that worked so hard to pull this together. Pa Snyder, who continues to translate the town hall into Spanish for us. I was going to be the backup, so I'm happy you came, Paz, because there were going to be some challenges with the translation. So thank you so much. Thank you. They heard me practice beforehand, and it wasn't pretty. So thank you very much for coming. Also have to give a wonderful thank you to Tricia Pachowski, to Jordan Pohl, to Amber Bosnow. Want to give a huge thank you to our partners in co-sponsoring this event, Michigan Medicine Community Health Services and Alfreda Rooks for the hard work she does as well to get the right messaging to the community. I have to give a shout out to my friends and colleagues on the Michigan SEAL team, which is a research team recently funded that I co-lead with Dr. Barbara Israel and our phenomenal 15 community members on our steering committee, including Yvonne Lewis, who keep us on the straight and narrow, to keep us doing the right thing for the right reasons, which is for one another and for the community. I thank you for making this event possible and helping co-sponsor the event, as well as the Washtenaw County Health Department. We will continue these monthly until you tell us you don't need them anymore, and look forward to bringing folks back. Our next event will be in February, and will feature Hamina Lovelock as our community and public health expert and moderator, as well as we're inviting back Dr. Cinti to continue to speak to us on the medical aspects of the vaccine and of the virus. We're going to work hard to bring people from across the state because we want these events to be representative of the entire state. I look forward to having you join us. We also want these events to be accessible and inclusive, so we will continue to have translation available as well as closed captioning. If you have any suggestions for how we can make them more accessible, please share with us because that is our goal. I want to go ahead and end on time. We have, it is 6:59, so I will say thank you to the 60 plus people who joined us tonight. Please spread the word. We would love to have even more people join us in February. As Yvonne mentioned, there's weekly events talking about COVID that are sponsored by the HFRCC in Flint that are on Fridays at noon, that are also a great source of information, and also wonderful, a number of other events sponsored by the state health department. So inform yourself, get your questions answered, empower yourself so that you can make the right decision for yourself, for your family, for your household, for your community, to keep your community safe. That is what we want. Thank you for joining us. We look forward to seeing you at our next event, which is on February 23rd at 6 p.m. We will be pushing out flyers and information, and stay safe, stay healthy, stay socially distanced, stay masked, keep your hands washed, don't touch your face, et cetera, et cetera. We are still on the journey. We can't stop yet, but we're making good strides. And if we all work together, we will keep each other safe and we will keep each other healthy. So thank you. And we will see you next month. Bye.
Bye-bye.
Bye.